Welcome to the National Council on Interpreting for Healthcare's monthly podcast, sponsored by the Standards and Training Committee. This podcast is intended for you, our members, the public at large, and everyone working to promote language access and social justice. Join our conversations with some of the best in our field and hear what they have to say about interpreting for healthcare. My name is Yulia Spirov, and I'm a member of the Standards and Training Committee at NCHC. Today we have an amazing guest, Allison Larimore. Allison is a trauma and vascular research nurse for the Department of Surgery at University of Washington at Harborview Medical Center. Allison works on all types of studies for both inpatient and outpatient worlds. Allison first started out as a volunteer and spent about 9 years working in the adult and pediatric burn trauma ICU and acute care units here at Harborview. Allison is passionate about equitable access to research. And Allison's work has recently caught the eye of the NCHC because she recently gave a successful keynote speech at the Institute of Translational Health Sciences Networking to Enhance Development Research Conference. In her speech, Allison shared how her inquiries and experiences led to the start of critical conversations to overcome the common obstacles researchers face when aiming to improve equitable access to research regarding limited English proficiency populations. Full disclosure, Allison and I both work at Harborview, and we have partnered before to talk about the important work to make research studies accessible to patients with language of care other than English. And therefore, it is my huge pleasure to welcome Allison on the podcast today. Welcome.
Thanks for having me. I really appreciate it.
Great. Well, Allison, as you know, we ask all our guests the same 3 questions and kind of get the conversation going with the first question. Looking back, what are you most proud of?
So looking back, I like to share this with everybody about Harborview. So I grew up in a really small town. It's much larger now because, populations grow over time. But every time that you'd hear a helicopter, you'd hear it go and you'd have to stop. And my mom was a nurse, and I would always wonder where that person was going that was in the helicopter, because that meant somebody was hurt. And they were airlifted to Harborview. And so growing up, my mom was a nurse, so therefore, I followed her footsteps and I became a nurse as well. But I always wanted to work at the place where the helicopters went. And I'm living my dream, and I'm very proud of what I do for work. And I really do love Harborview. I love Harborview for what it stands for, our mission population, and just my coworkers are everything to me. I really do enjoy it. But what am I most proud of is my most recent work and my culture of inquiry about making sure that there is equitable access to research for all of our patients here at Harborview and the University of Washington system, make sure that we are providing the opportunities. So the work that I've done is the collective work that's been happening. But I think a lot of people have felt stagnant or siloed, if you will, and then just making sure that people are collaborating and partnering with each other, like working together with your team, my team, teams throughout, and connecting people, with the internal review board and whatnot. So asking those questions that people are probably having. I'm just a loud nurse who's trying to get the attention and get things changed. So I'm excited, and I'm very proud of the work that my coworkers and I have worked on.
Thank you for sharing that, Allison. I think you should absolutely be proud of that. Let's take a little step back, because you and I share this common background, right? We know exactly what Harborview is. We know exactly why we're both living the dream of working here. So let's talk about what Harborview is for those of us, because this is the National Council for Interpreting in Healthcare. People will be tuning in from all over the U.S. and maybe even outside the U.S. So let's talk about what Harborview is and what kind of role it plays in this region for healthcare. Would you say a few words?
Yeah. So Harborview Medical Center is really special. We're the only level 1 trauma center that serves Washington, Alaska, Idaho, Montana, and then sometimes Wyoming, but we serve everything. So if you are burned, or if you're in a car accident and you're a kid, you get airlifted to Harborview, and that's part of what I did when I was working in the burn and pediatric ICU. So we got patients from all over Alaska. They'd be airlifted to us. They would get stabilized in Alaska, but then they would fly down to us to receive care here at Harborview because of the specialty that we provide. We serve the underserved. People come from all over. People speak all languages, different walks of life. It's a wonderful place to work. I mean, I don't know. I can just keep going on and on.
Okay, great. No, I think this is a great information for our listeners and viewers to have. Now, let's again take another step back and talk about research. And if you could say a few words about how research works in the units that you serve and have served, what is the internal review board? And also, why is it important to make sure that everybody has access to these research studies? Why are you doing the work that you're doing?
Yeah, so a lot of the work that I do is a little bit different from what I'm finding out, right? So I'm so used to the inpatient world, working as a bedside nurse, where using, the translator phones or having interpreters at the bedside or the cultural mediators is just second nature. So then I moved to research, and I'm still working with the same people, patient-wise, but then language is a barrier. And it was just very humbling to come back and be like, but that doesn't sit right. Why are we, what is it, the government? Is it, the governing internal review board who approves our protocols and what we're allowed to do or not allowed to do? Or is it a systems issue? What is it? Is it financial issues? That's a barrier for us. And so just really stepping back and completing my orientation and making little notes and just starting to ask more and more questions. And it's just snowballed into figuring out how can we all want the same thing. We all want to be able to provide our patients with, equitable access to everything. And that includes research here at Harborview too, and University of Washington. So the type of research I do is trauma research, right? So trauma research doesn't discriminate. Trauma doesn't discriminate. Burns don't discriminate. A lot of injuries and things like that, they just don't. So it really was hard for me as somebody that was so second nature to just care for my patients in the manner that I'm able to against, for our policies and procedures. And to have exclusions of, English speaking only, or we only have Spanish or English consents translated. So therefore we can only enroll subjects that are English or Spanish speaking only. And then I started to track patients that were other languages, and therefore, but they qualified for research for our various studies that we work in. And the interesting thing about my research that I work on with my team is we do trauma. So we are in the ER. I mean, I was just in the ER 5 minutes before I came onto this, and we enrolled a subject. I didn't need to worry about what language they spoke. I provided them. These are safe, approved. They're governed, by not only the internal review board, but they're also governed by the FDA, and we're monitored and we're audited, and we need to make sure that we're providing safe care. It's just so nice not to have to worry about that. But with other studies, I have to worry about that. And, in the ER, it's chaotic. It can be very quick. And a lot of my studies that I have right now are very fast acting. I have to be enrolled, randomized, and treated within 90 minutes of arrival, given the patient's injuries. Some of my other studies that I work on are device trials, and I'm working really hard. I'm very proud of the work that I've done with my colleagues that I've been, working on. That study's been going on since early 2010, 2011. Only English speaking has been enrolled until I came on. Within the first about month and a half of me being on board, we enrolled a Korean speaking gentleman. And I'm very proud of that because he received care that he might not otherwise have received because of this investigational device is so unique. And so we're longstanding working on that. Very proud of that. And I have so many examples. I mean, another study with us in the emergency room, quick enrolling, 6 out of 26 subjects all speak other languages other than English. And so it's really proud work that we're doing, but at the same time, I know very well that 2 years ago, it probably wouldn't have been happening or very limited. And it's not fun to see a patient and see their name, and then you have to, but they're not able to speak for themselves. And so you kind of have to, are they an epic what languages are they, are they listed? Does anybody know this patient? Do they have somebody with them? And so just to get away from that thought, because it doesn't feel good, right? Like we have to do that, but it doesn't feel good. And it doesn't feel right because it feels like we're doing a disservice to our patients. So to be able to provide that, and we're not like doing like crazy studies, we're doing, drug trials that are already approved by the FDA, and we're just using them in a different manner to show that they are or are not safe for, the populations that we're intending to treat with. So I think that's something that's very unique to trauma research. I don't really have the luxury of being able to call quickly for an in-person interpreter. These things are not planned. I have to rely a lot of the times on phone interpreters. And I think the more that we're doing this, the more that we're going to start utilizing different ways of communicating with each other, developing policies and procedures to make sure that we are following what we are supposed to be following, and making sure that we're holding each other accountable, making sure that we're having courteous of your guys' time, right? Your time is also money. And so if we're wasting it with just like a 4-minute phone call, like we need to make sure that we have other contacts, and then also being courteous of what you guys are witnessing, right? Like I can tell you that if you were just down in the ED with me, you probably would have canceled our meeting. So having that and watching that I think that's just one, being a human, but also working with the interpreters in the burn unit and the pediatric unit, and the cultural mediators who would come to the floor. I think we were pretty good about taking time to say, how are you doing as an interpreter? Do you understand? Do you have questions of what you just witnessed? Do you have questions? What do you think the patient should ask for questions that we may have not covered? Really taking the fact that you guys are humans as well. You have emotions. You just witnessed something that you probably don't see on a daily basis, that I do see on a daily basis. And so just reminding to have grace for each other, and then we're all just trying to do our best. I think that's the most important thing. But it's hard work here, but it's also really fun. It's really exciting. I love what I do right now because I do get to enroll so many people that do probably otherwise may not have the opportunities to enroll. That doesn't mean I have every language in every single study, but that's a goal of mine, to have every language available.
Wow. Thank you for that, Allison. There are several things that I want to address that you just said. First of all, thank you for taking care of our interpreters. So for those of you who are listening, and when Allison says you and you guys, I work at Harborview Interpreter Services. So Allison is talking about both our staff interpreters and also our vendor partners that we work with to cover all of our daily encounters. And thank you so much for looking after them, because Allison, it's not something that I hear very often. It's not something that I know many interpreters experience, especially if they're not staff, especially if they don't have the same badge that you and I have, when they're more recognized as part of the healthcare team. So I think on behalf of every interpreter who is, working on the phone, thank you so much for considering interpreters' feelings and interpreters' experiences, because just like any other member of the helping profession, interpreters are very much vulnerable to vicarious trauma and potentially, a little bit less maybe if they weren't seeing what you're seeing, but still, it can definitely leave its mark. So thank you for that. And then, for your work, making sure that everybody's enrolled who is eligible regarding, regardless of the language they speak, the preferred language of care that they have. I think that's tremendous, because I will tell you, personally, there is a health issue I have that I benefited from a clinical trial because of how insurance works. It's not a treatment that is readily available to me, and it's too expensive to pay out of pocket. Right. And so I'm so grateful that I got to, to try the treatment out, even though ultimately didn't end up working for me. But at least I know, and I didn't have to spend thousands of dollars out of pocket to figure out. And so it sounds, correct me if I'm wrong, but this is a very important issue of equity of care, because access to clinical trials allows patients to receive treatment that they otherwise might not, just because maybe it's not out there and widely available. Maybe their insurance doesn't cover it, or for whatever other reasons, but a clinical trial can provide you access to that treatment that you otherwise might not get. And then if you don't speak English, it's not that you can't enroll, you might not even be considered for enrollment, right?
Correct. You won't even, and that's the whole point of equitable access to research. It's not necessarily always my decision or the primary investigator, the head doctor's decision to enroll the patients. It's the patient, when they're able to, make that decision. But who am I to deny them that opportunity? So they don't even know. And so I use I try to reset people's framework and mindset of saying, imagine that you could have a clinical trial and you know about it. And, it's going to potentially save your right arm or whatever it is. Like you're sick, right? You need help. And then you go to another foreign country to get that treatment, but then you don't speak that language. You don't get the trial. It's really hard to think about. And so when you remove people from, our everyday, and I know why, because we're trying to protect people, but if we're doing the same care and protecting no matter what, and following all the rules and the regulations, we should be able to at least offer the opportunity. And I've been declined for research opportunities. I mean, my patients tell me no, and I say, okay, please elaborate, make sure it's not, maybe I said something incorrectly, or maybe I need to clarify a little bit more, or they just flat out don't want to be a research subject, and that's okay, that's acceptable. But at least I know I was able to offer or potentially offer the opportunity to them. It's not always my decision, or by my decision, I mean my protocol that I'm held to is decision. I think that's really important, that patients know that they have those opportunities. I've had people where I go back and I talk to them about, hey, your mom and dad said you could participate in this study. You weren't able to speak for yourself because of your critical illness. Let me tell you about what we did for you and what's going to happen in the future. And, I got this many more lab draws I got to do on you, and I'll try to coordinate, blah, blah, coordination with them. People just look at you and they're like, thank you for including me. That makes me feel really good to know that it's not just my regular doctors keeping eyes on me, but another team is also keeping eyes on me to make sure that I'm safe, that something's not being missed. Because I tell them, I say, we are watching. We might catch something you don't know, or the doctors, we might find out earlier and say, hey, this actually might have been a potential side effect of our drug or our device, or, hey, let's get you in for another scan because we really want to look at this a little bit more closely. And I think that's something that's so special. And everybody deserves to have that option. They really do. I think the other next thing is kids. I think people are so scared of working with kids, and that's right? They're a vulnerable population. But at the same time, burns impact children so much. As a pediatric burn nurse, it's very scary how many burns actually happen. And you got to remember, I have multi-state, so everybody comes to me, so it feels like a giant number of people. But not a lot of research studies are done on children. And so to help not only, break down the language barrier of enrolling patients into research, but also then breaking that pediatric barrier of saying no, it's okay. Children's also does it. We can do this as well. If Seattle Children's can enroll subjects into clinical trials, we should also not be afraid of them here at Harborview Medical Center. We should also give them the opportunities, if it's appropriate, to give them that access. So I think that's, it's just a fun place to work.
Absolutely.
I mean, I know you know that, you work with me. But...
I do. Here's another question I have for you, kind of to follow up, and it might really line up with my next question about the challenges that you're currently experiencing. So as far as language access for somebody who has a language of care other than English, so the examples of language care provision, language access provision would be, of course, interpreters, right? As you are discussing the possibility of enrolling them, as you have ongoing conversations about how it's going. But then another big piece of it, and that's the piece that you and I worked on, is document translation. Why is it, and so clearly, whenever a patient comes into contact with anything to do in healthcare, they have to have informed consent, right? They have to know exactly what's happening to them, what the risks and benefits are. but it's even more important in clinical research. So can you talk a little bit more about, the importance of consent forms in clinical research and why it is so important to get them translated?
So we're currently undergoing like the short form consent translation. So it's just a 1-page document with lots of information on it that basically says, this is why I'm in front of you. And the interpreter's reading it graciously, or I'm reading it to the interpreter, depending on the situation. And then they're translating it to the patient, and it's explaining why I'm there, right? Like, why is this woman standing in front of me who's not my physician talking to me about something? So I'm consenting the patients for this clinical trial. And so I have to tell them basically. And what we like to do for our department is to read the entire full English consent to them. And have it translated by the telephone interpreter or in person. Ideally, it would be best to have it written translation. And then also it's teaching people to take a moment back. And this is my nursing background, right? Can you even read it? Can you read the top section to me to make sure, the medications aren't impacting your eyes, or just to make sure that maybe they wear reading glasses. That happens because you can pick up on these things as you're a nurse, or if you're working more around patients, you can tell they might not be able to read. And why aren't they able to read? Is it because they truly can't because of literacy? Or is it because they don't have their glasses on? Because they're just in a trauma. Where are their glasses? It's probably on their nightstand table. We don't know why. And so getting them those reading glasses, Harborview is able to provide those for some of our patients, and then they're able to read the consent. But I can tell you, I read a lot of consents to people who are English speaking for any other reason. But as well, these consents are so long. Some of them are not, one of my consents are 19 pages, front to back. So 19, it's very long. 19. And so you have to step back, and this is how my mind works a little bit, is how much of my time, the interpreter's time to not only translate the document, but also to reverse translate the document. How much is that going to cost, right? And then the follow-up time of both parties to consent this patient. So would it be feasible and realistic and financially savvy of us to translate the entire document one time?
Interpret out loud. So out loud interpret, because we're using because we're using both terms, interpret and translate. I just want to So we're talking about interpretation.
So if you're speaking, using the time while we're speaking to each other.
Okay.
Or is it more financially savvy to have the written translation? Yeah. Sorry for not clarifying. The written translation. Mm-hmm. So is it, financially appropriate, or is it, you're seeing that language again and again? Because the short form is for the unintended or infrequent encounter with that language for your study. You don't have time, you don't have the means to translate the full consent. I can tell you that at any time, I will always try to have the written consent translated fully. One, the patients get to go home with a document that they can hopefully read in the language that they can read. And they're not given a 19-page packet in English that they're never going to pick up. Technology is there, but it's also not great yet. It's not perfect. And you can't really take away the human interaction. And you can teach a computer things, but you can't teach like cultural norms and, body language, reading skills and things like that. So I think that's something really important. It's such a big deal, I think, going through and reading the full consent, because these patients need to know. And I find the more time that I spend on a consent with a patient for research, even in English, is doing a lot of teach back. Tell me in your own words what I just talked to you about. It can be really rough. You just because they look at you like deer in headlights, and you say, no, really just rough. What am I offering you? What is your commitment? Give me 3 side effects. And if they rattle or take too long, and then I say, okay, well, give me 2 more, just so they really understand what they're getting involved in. Research can take a really long time commitment. Some of my studies are till the end of their hospital stay, which is 30 days, sometimes longer, sometimes shorter. You never know. Some of my research studies are up follow-up for 6 months. And some of those follow-ups are labs, some are follow-up surveys, some are follow-up phone calls, or actual commitments to coming back to the hospital for physical exams and more lab draws. And lots of surveys. And then, my device trial is greater than 5 years. So I am following and tracking patients and seeing them in clinic and following their healthcare for 5 years and on, and making sure that they are safe. So it's really important for us to not only be able to speak to our patients, right? And so using our hopeful in-person interpreters or telephonic interpreters, but also having written paperwork, the written discharge paperwork for when they're going home from the hospital. It needs to be translated. When is their follow-up appointments? Make sure it's translated for the patients and they're able to have a written copy, because people will forget. Mm-hmm. Have you ever been discharged from a hospital? It's very overwhelming. I have. It's very overwhelming, and I'm a nurse.
Yep.
And you get sent out, and then you go home and you're rifling through your paperwork. And I can't even imagine if only 2 forms were actually written translation and then the rest were all in English. And I don't, that's not my primary language. I think that would be really confusing. And I think that you would have lower follow-up rates for your patients. And we need to make sure we have good follow-up so we can show the governing bodies that our research is either safe or not safe, and we're finding out of adverse events or, things that might be going wrong throughout the study, and make sure our patients are safe. So I think that's the big thing, is making sure that it's not just like picking up the phone and talking, to a telephonic interpreter. I think it's also just like the holistic picture. It's not just this one-time interaction. It's a longevity interaction, and we need to make sure it's sustainable. The patients are okay with that. And they need to know that they can ask for the interpreters too. I think that's also important. We all know that because I'm talking to a group of interpreters. But
yeah, absolutely. And let me just tell you, I love your piece about Teachback so much. That's another just a stellar example of working with anyone, really, with English, with fluent English speakers too, right? But it is such an important piece of communication, and making sure, as much as I spend a huge chunk of my time telling people, please work with interpreters, please let us, help you communicate. But things do get lost in translation, right? And so having that, or not just necessarily in translation, but just in the moment, because like you said, people are going through trauma through all of these events. And so making sure that we catch whatever's lost, and have it there. So that's wonderful.
Yeah.
All right. Well, I have my last question for you, which is, looking forward, what would you love to see happen? Let's dream together.
I think my dreams.
Well, I might, but let me tell me again. Tell me again. Tell everyone again.
I want to be able to approach and offer any of my clinical trials that are appropriate to any patient. I don't want to have it be a barrier or a second thought of like, ooh, do I have Mandarin? Do I have Vietnamese? Ooh, do I have Punjabi? Like, which, yes or no? And if it's a no, then I can't approach, because how rude it would be for me to show up, offer the research, and be like, oh, sorry, I don't have Punjabi. I can't enroll you. Sorry, never mind. You don't get this opportunity. It'd be terrible. So that's why you make sure that you have what you available and what you're approved to do earlier on while you're screening, because we have such a wide variety of patients that come to Harborview. And I think to not have that be a second thought, or like that nagging background thought, I think that's something, it just feels good to be able to not worry about that. My other big dream, and it's actually happening, is to have forms already pre-translated. So pre-written translation. That's slowly rolling out. Thank you to, University of Washington Internal Review Board for, already feeling aligned and working on that as well. And so that's actively in the process. It would be a dream to have it be the full consents, or like portions of the full consent, so we don't have to pay as a research team per, study to have certain areas translated again and again and again and again in written form. And then thank you to the government. They are passing laws and bills, and things are moving through the system to where we have to provide demonstration of how we are providing equitable access or recruitment strategies and opportunities to other populations. And it's just really nice to think things are moving along in the forward direction. And it just so happens that it aligns with what I envisioned for our hospital. I think one thing that I would be really interested in seeing is we're moving to a electronic regulatory kind of technology in a way, instead of printing out masses and masses of pile of paper, like what's behind me in these file cabinets, is to have the interpreters, telephonic or in person, if they know they're going to be called at any time, do they have access to that e-regulatory system? So they have access to the full consent. So I don't have to read 2 or 3 sentences or 2 sentences and then wait, and that way you guys would just have it. And it's the most current version. There's no, oh no, sorry, I forgot to send you the most current, it's like that delay is gone and you just know that they have access. I don't know if that's possible, but a girl can dream. I think that would be really helpful. I tried emailing a consent ahead of time to the telephonic interpreter services, but unfortunately never made it to the actual interpreter that I needed. And so then we had to sit, and she goes, yes, I agree with you. I wish I would have had the written consent in English ahead of time, because it's also overwhelming, right? Like, can you imagine given a 19-page document with pictures and graphics and things that you've probably never even heard of in the human body? And, oh, by the way, can you translate this for me? And help me answer any questions and translate that back and forth. I think it's just courteous of us to kind of plan ahead. I think that if there was a way or some way, without increasing the research staff study burden, to have an easy way for the interpreters to have access, because you guys are a member of the team. I don't care what anybody else says, you guys are. So you should be able to have the access to it. And so that's something when I work on that committee, is to see if we can strategize a way to make sure that you guys have the most current, up-to-date regulatory paperwork for the consent. So you can say, hi, this is Allison. I'm with Trauma Research working on study ABC. We're going to consent a patient. He's in front of me right now in the emergency room. Can you help me? And they say, what language do you need? And I'll say Spanish or whatever language. And then it routes to that person. And then that interpreter is able to log into the system and pull the study consent for ABC. And we verify that we're on the same date. We're golden. Like, that would just be so cool. So cool if we could do that.
Yep. And if they actually have a translated version too.
Oh, even better.
So you're looking at the English version. They're looking at the language specific version. Everyone is figuratively and literally is on the same page.
Literally, yes.
Literally, yes, on the same page. I love that.
That would be, yeah. So I think, we can use our technology in the way that we need to, but at the same time, we can also be courteous of each other's time and kind of the whole picture. I think that's something really, and the patients. The patients need to have a complete holistic understanding of what they're getting involved in. So I think just that, and developing policies and procedures to help support those, making sure that people know and the interpreters know exactly where, if they want to be the witness, to sign where they sign. That way there's no like, well, do you sign here or do I sign here? Or no, I don't know. Like, there's none of that, back and forth of, we want to make sure your staff's comfortable, but also my staff's comfortable, my coworkers are comfortable. We're good. We're following all the rules and the regulations. I think that's also very important. So
yes, and many consent forms are evolving now to where there's a field for an interpreter, because we acknowledge that they're there to do a particular job, not as a witness, not as a support person, but they, interpreted something. And so I think that's also something that I'd like to see everywhere. First of all, recognizing that if you are obtaining a consent form from somebody whose preferred language of care is not English, so you see that field there, and it gives you a pause potentially, right? Am I working with a professional interpreter? And then having a way to trace that back, and kind of understanding that this is the role that the interpreter played here for you, right? They helped the patient understand what they, like you said, what they were signing up for. So, great. Well, wonderful. I think this is a wonderful note to end on. And Allison, thank you so much for coming in, and thank you for just all of the consideration you give to making sure that everyone who is eligible and willing to participate has an opportunity to do that, and to receive potentially life-saving or limb-saving or otherwise vital services, whether it's a device or a medication. And thank you so much for your thoughtfulness towards all of the interpreters and document translators you work with, our team, or all the other teams. I'm sure everybody who's listening will feel the same way, like that warm and just grateful feeling. And I'm really looking forward to hearing how, to following your career along and seeing what you're able to achieve. I'm sure, like a pebble in a pond, your intentions will spread, and but I cannot believe that, or I should believe this is Harborview, right? It's full of amazing people, but I'm just so glad to meet such an ally, and you're amazing.
Thank you. I appreciate it. I think that's the biggest thing is that I've talked to probably well over 100, well, more than 100 because of the conference, but it's nobody's been a naysayer of like, oh, we can't do that. No, 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 no. The regulatory says this. It's always been, oh yeah, I wish we could do that too. Or, oh, I wish this, oh, that's happened to me before. And I wish I could, I feel really guilty. Well, why are we allowing it to continue? That's of like, what do I know about this hospital and this hospital system? What do I know what's right for my patients? What do I know that's right for research? And what's the right thing to do? And so I think using those connections and connecting each other with that, it's just kind of fun to sit back because I mean, there was like a 6-month period where things didn't feel like they were happening at all, except for with what I was doing with my own core group. And then it's just like rapidly snowballed. It's like literally like a snowball is now the size, and it's just growing. And it's fun because it's also not just me doing it. It's also watching other people feel empowered. And I, working with another group, they were like, we just got approval to have this language. And I'm like, was celebrating in the hallway because they felt like they could finally, take a step up and ask and change the way, because the worst thing you could tell somebody, especially at Harborview, that's the way we've always done it. I think that's anywhere really, but
Absolutely.
yeah. Well, thank you.
Thank you, Allison.